Welcome to Health Equity in Focus. This is the Access to Medicines and Intellectual Property podcast of the Third World Network, where we share insights and critical analysis from a Southern and equity perspective. I'm Rania De Vito of the Third World Network, speaking to you from Brazil. Today, we have the privilege of speaking with K.M. Gopakumar, an expert in global health policy, a legal advisor, and a senior researcher at the Third World Network. In May, the World Health Organization adopted amendments to the international health regulations. For some, this was a historic moment. Gopa closely followed the negotiations, attending sessions in Geneva throughout 2023 and 2024. He will share his insights with us today to help us understand what was amended in the international health regulations and the public health implications of them. So thank you for joining us, Gopa. To start off, could you please introduce yourself and tell us a bit about your background and experience in global health?
Thank you, Hania. It's a very important issue, and I'm very glad to be part of this podcast. And last 15 plus years, as part of my work, I have been following the developments related to access to medicines issues, also some of the governing issues related to WHO, including the framework for engagement with the non-state actors. As part of any organizations or individuals who are following the global health issues, I am in a way forced to look at the developments related to the norm setting activities during the post COVID period, especially the amendment of IHR as well as the negotiations on pandemic treaty.
So, Gopa, for our audience who might not be familiar with the topic, could you explain what the International Health Regulations, or IHR, are, their origins, and their primary objectives?
International health regulation has a long history. It is originated from the various international sanitary conferences happened in the 19th century. And when WHO was formed, it was known as International Sanitary Agreement. But by 1969, International Sanitary Agreement has been revised and got its name called International Health Regulations. And this International Health Regulation was further revamped, and actually a new regulation was drafted under Article 21 of the WHO Constitution in 2005. This regulation basically creates an obligation on member states to inform the WHO whenever there is a outbreak of diseases which has a potential to become a public health emergency of international concern. In order to fulfill that obligation, the countries are having another subsequent two obligations, that is to maintain core capacities in disease surveillance as well as to maintain a core capacity in public health response. But at the same time, there was no effective tool or mechanisms created under IHR to assist countries to implement these obligations in an effective way, because the IHR does not take into account effectively the development divide existing between developed and developing countries. Though it recognizes that many developing countries do not possess the ability to fulfill their obligation, but there was not effective mechanism like a financial mechanism or a clear obligation to assist these countries to fulfill their obligation. This was the main criticism, and especially in the case of equitable access. As a result, the IHR became an instrument which provides information to WHO and through the WHO to other member countries about the disease outbreak, and helps that other countries to take various measures to prevent that disease to affect their own population. So in practical terms, it means most of the diseases outbreaks are taking place in the global south, and the global north get the information, and this plays out like a one-way traffic where the south gives the information to the north, and north does not have any corresponding obligations to help the countries to contain that outbreak at a local level. IHR in a way maintain the colonial legacy of using the information to protect the population of north without any corresponding obligation to help countries who are facing the outbreak to contain in an effective way.
I think that's a very interesting perspective that you brought on to think of global health in a long-term history that is very connected to colonial roots and how global health is established in these pillars. I guess this leads me to my next question, which is, What were the main reasons or events that prompted negotiations to amend the IHR, International Health Regulations? Can you give us an insight into the 2-year negotiation process, its ups and downs as well?
Sure. After the outbreak of COVID 19 in a large number of WHO member states, especially developing countries as well as developed countries, there was a feeling of outrage due to the inequitable access to various health products which are required for the effective response to COVID 19. So they started looking at what is the legal instrument which is supposed to perform these functions and what are the gaps. And this basically forced the WHO members to take two initiatives. One is an initiative to create an IHR review committee to look at the effective response to COVID 19. And second is a working group looking at the health emergencies. That is a member state driven process. The first one was a expert driven process. So at the same time, there are a group of countries also announced that there is a need for to create a new legal instrument to effectively prevent, prepare, and respond to the pandemic. At that stage, US proposed amendments to IHR, and many other people also felt that the fundamental instrument to address these issues is IHR, and there is a need to strengthen IHR. And at the same time, there was a special World Health Assembly session which took a decision to have a new pandemic instrument. So by end of 2021, it was very clear that there would be two negotiating tracks, and one will be looking at the amendment of IHR, and another track will look at the negotiations to conclude a international legal instruments on pandemic. So we had two processes. One is known as the Intergovernmental Negotiating Body on Pandemic Instrument. Another one was a working group on IHR. These two processes had 10 plus round of meetings, negotiations, and at the end of May, it became very clear that the pandemic instrument cannot be concluded by the 77th World Health Assembly. At the same time, there was a consensus that they would be able to conclude the negotiations on IHR amendment. And 77th World Health Assembly adopted these amendments. And now there is a 1 year left for the member states who wants to disassociate. They can inform the WHO DG. Otherwise, the agreement is going to be applicable to all member states. INB negotiations will continue for 1 more year and supposed to be concluded by May 2025.
So, for our next question, could you provide us with an overview of the different proposals put forward in the negotiation process to amend the international health regulations? In particular, could you give us an idea of what were the positions of developed and developing countries?
It is important to keep in mind that the formal decision to amend IHR was taken by the executive board, which met in 2022 January. That amendment decision was clear, which spell out clearly the scope for amendment and which clearly spell out the need to incorporate provisions to ensure equity in IHR. Then there was a decision by the World Health Assembly in May, which formally provided a deadline for countries to submit amendments. So there were around 12 countries submitted the amendments, plus another four more countries on behalf of various regional groupings also submitted amendments to IHR. So you can say that around 16 set of amendment proposals were submitted, and these amendment proposals were referred to an expert committee known as the review committee. Review committee went through these amendments and put their technical recommendations to the member states. And the working group on IHR started the negotiations on IHR amendments. If you look at these proposals, though there was a reference to equity, the developed countries' amendments were by and large looked at creating an obligation on all the state parties to provide more information, more swift way to WHO. That was the main focus. And developing countries' amendments were by and large looked at ensuring equity, as well as a set of other amendments were looking at streamlining the technical documents like vaccine certificates, etc. But the north-south divide was very clear, and the preference were very clear.
So So can we say that the WHO Executive Board decision that initiated the negotiation process, highlighting the challenges of equity and technological divide faced by developing countries during health emergencies were met? Do the adopted amendments sufficiently address these issues?
So, what were the main shortcomings of IHR? First, it was a development blind, or in a way, overlooked the development debate existing in the international political economy. So, as a result, it basically treated unequals as equals, or unequals on an equal footing. And as a result of it, there was no provision for providing equitable access. There was no provision for financial assistance for the effective implementation of IHR. And third, there was no institutional mechanism like a conference of party or a meeting of parties to discuss these issues and take it forward. There was only one mechanism to address that was in the World Health Assembly, which in a way failed to provide sufficient time to address these issues. So now, if you look at the amendment, first of all, in principle itself, equity and solidarity has been recognized as an important principle for the implementation of IHR. Not only as a principle, but this has been further addressed in the subsequent articles. So most important article, I would say, Article 13.7, 13.8, and 13.9 in terms of addressing equitable access. 13.7 creates an obligation on WHO to coordinate with other existing mechanisms or networks to put it in place a coordinated response to a public health emergency of international concern as well as during a pandemic emergency. Article 13.8, which without any qualification creates an obligation on WHO to address barriers to equitable access. And then it spells out other three obligations. For instance, whenever there is a PHIC is declared, now there is an obligation on WHO DG to come out with a report on accessibility and affordability of health products. This was not there earlier. And all the other recommendation WHO is to make under Article 15, 16, now WHO has to take into account the equitable access. Then similarly, Article 13.9 creates an obligation on the member state to assist WHO to fulfill its obligations. Of course, there are qualifications when it comes to member states to the extent possible, etc. But it's formally for the first time puts an obligation on member states to assist WHO to address the issue of equitable access. But please keep in mind the obligation on WHO has no qualification. 13.8, the chapeau. And similarly, Article 44 bis, a new article has been adopted, which creates an international financial mechanism. And one of the mandate of the mechanism is to mobilize resources, new and existing resources for the implementation of IHR. This is a very important obligation. It clearly provides an obligation to mobilize finance. So, in a way, it can address the issue of lack of financial resources for the implementation of IHR. And lastly, it creates an implementation committee to address these issues. And there is also an obligation under Article 44. The DG has to submit a report on the technical assistance provided under Article 44 to the implementation committee. So, in a way, you have all these obligations and you have an institutional mechanism to discuss the issues of equity. So, I hope that will create a momentum to further the issues of equity in the context of international health emergency preparedness and response. But at the same time, there is a role for the vigilant civil society organizations as well as member states to pursue this cause because the provisions are have not spell out all the minute details. So therefore, it is each time you have to press for it, but now there is a venue to press it, and there is a clear mandate to press it. These were missing. So in a way, this is a significant, important step towards achieving equity in the international health emergency preparedness and response. But at the same time, we should keep in mind that these are broad obligations. Details are not spelled out, so efforts needs to be put. But there is a mandate to put that effort.
And what are the mechanisms in place to ensure that countries comply with the regulations?
Well, some scholars complains that the IHR amendments lacks the complaints mechanism. For them, I think the complaints mechanism means something like you have retaliatory mechanism to ensure that the member states follow the rules. The IHR mechanism does not have that kind of complaints mechanism, but it does have a broad complaints mechanism. At least every member state has to report to WHO annually on the implementation of IHR, as well as there is an implementation committee wherein which the member states can discuss the challenges they are facing in the implementation. So these two mechanisms, like we do have it in the human rights treaties, through the reporting and through the assessment of their reports, you can ensure a kind of a compliance to the human rights treaty obligations. So similarly, the implementation committee and the reporting mechanism will in a way ensure the compliance, and we also keep it in mind that the member states undertake these obligations in good faith. That's one of the fundamental principles in international law. So therefore they are expected to comply with these respective obligations.
Thank you, Gopa. So, for our next question, the IHR amendment negotiation process was happening in parallel with the Intergovernmental Negotiation Body to negotiate an international instrument for pandemic prevention, preparedness, and response. While the amendments to the IHR have been adopted in the World Health Assembly, the negotiation on the international instrument is still ongoing. So, what, in your view, is the link between the recently adopted amendments to the IHR and the negotiations for a pandemic instrument? How should developing countries approach the negotiations for the pandemic instrument?
The conclusion of IHR amendment negotiation provided a clarity that a pandemic is an elevated form or more acute form of a PHEIC, which is affecting many countries, maybe intercontinental in nature. So, therefore, more intensive responses are required. As a result, the obligations of various parties in this context, especially the need for equitable access, should be beyond what is there in the IHR. So I would say that the obligations on equity and the demand for equitable access should be placed something like an IHR plus framework. So in this regard, developing countries need to demand much more concrete equitable access related provisions and equity related provisions in the pandemic, because pandemic is danger which goes beyond PHEIC. And second, developing countries needs to argue for a mandatory technology transfer of publicly funded pandemic related products. And similarly, the developing countries needs to argue for a PAP system, that means the pathogens access and benefit sharing system based on fair and equitable benefit sharing emerging out of the sharing of pathogens. And thirdly, there should be a financial mechanism. Financial mechanism is already created under IHR that needs to be linked with the pandemic treaty. And lastly, I would say that the normative footing of this instrument should be at par with IHR. Now, the demand for a pandemic treaty will be under Article 19 of the WHO constitutions. So that creates a fragmentation of norms. Instead of that, the pandemic instrument and IHR should be on the same normative footing. That means both instruments should be under Article 21. Then we can prevent the fragmentation of norms and fragmentation of obligations. The task before the developing countries is to achieve much more coherence and achieve more concrete obligations on equity and equitable access in the context of pandemic.
Thank you so much, Gopa. I think you gave a great overview and you covered different perspectives and angles of the IHR and also laid out what is the challenge ahead. So I guess to finish, I would just ask if you would like to say something to the audience that you would like them to remember with respect to the recently adopted IHR amendments so we can close.
Just one word, equitable access is no more a charity, it's an obligation on WHO. That's all.
Thanks for tuning in into Health Equity in Focus. This program is brought to you by the Third World Network, where we advocate for the needs and rights of the Global South, promoting just, equitable, and ecological development. Hope to see you next time.